Thank you very, very much for joining us. Ayushman Bharat will be one of the biggest insurance and healthcare schemes in the world. It's been called by many names, whether it's Ayushman Bharat or Modi Care and whatever else you may call it, the Jan Arogya Yojana. But the question really is that this is a huge leap forward as far as the healthcare in India is concerned, and who better than Mr. Indu Bhushan, the CEO of Ayushman Bharat, joining us right here on ET Now. Thank you very much, Mr. Bhushan, for being with us. How big a step, how big a leap this really is? This is ambitious. You are looking to health finance an insurance cover of 5 lakh rupees to cover about 10 crore families, which will benefit 50 crore people in all to begin with. Isn't that very, very ambitious?
Well, thank you for having me over. Of course, it's a huge scheme in terms of the coverage and ambition. And you mentioned more than 50 crore people, as the Prime Minister mentioned on 15th August. That is population of Canada, US and Mexico combined. And in terms of coverage, we had RSBY, which was covering up to 30,000 rupees per family. Now the ambition is to cover up to 5 lakhs, which is 17 times the previous scheme. And also in terms of the benefit packages, earlier we were covering about 700 benefit packages. Now we've gone to about 1350 benefit packages. So in terms of the coverage, in terms of population covered, I think it's a much bigger scheme.
Right. No, it's a definitely bigger scheme, but one is interested to understand, do you have the requisite infrastructure to make this a successful scheme? Because the Rashtriya Swasthya Bima Yojana, or the RSBY as it's called, could never really take off because of lack of infrastructure. How are these two different as far as infrastructure is concerned? Do you have the requisite infrastructure to make this a roaring success?
See, infrastructure is not enough in the country, and that is the situation. That's the reality. Now, for last 70 years, we've been following a supply-side approach for strengthening infrastructure. That, of course, has worked, but has not ensured that the poorest of the poor, or bottom 40% people, get the benefit. This scheme, by providing demand-side financing, ensures that whatever infrastructure we have, we prioritize the poorest of the poor and bottom 40% people of the country. On top of that, we're also bringing the private sector into the equation. You have to note that private sector provides about 70% of the services in the country, and bottom 40% people are almost out of that because they can't afford to go to private sector or private sector for secondary and tertiary level care. So therefore, this scheme will change that. It will open up private sector for these people who rarely used private sector for secondary and tertiary care.
But Mr. Bhushan, the argument is about the community healthcare center. We've got one for an area of 562 square kilometer. Our doctor to population ratio in India is 1:1565, 1565 per current population of 1.33 billion. The WHO standard is 1:1000. You know, in some sense, you said you will be roping in the private players. Do you risk being at the mercy of private players? And how are you going to set this equation right? The 1:1565, the doctor to the the patient ratio.
Again, we need to have more doctors, but more than the numbers, the issue has been the distribution of doctors. Most of the doctors are based in urban areas and actually in top 20 large cities. And there's a reason. Of course, there are several reasons, but main reason is that that's where the paying capacity is, and that's where they can find employment. Now, with this scheme, we've turned that onto its head. We are providing large amount of affordability and rupees in the hand of 40% people who live mostly outside urban areas, or at least are outside these 20 big cities. Therefore, there will be more demand for services. and we foresee that this distribution of providers will also change in coming years. But more than that, actually, we also need to understand that government is doing many other things to support improvement in quality of services and access to services. One, we are creating more medical colleges. Every district is going to have a medical college in coming years. We are also increasing the number of AIIMS across the country.
Right.
So we'll have more specialist doctors as well. But that will take some time. But the issue is that the creation of those human resources, creation of facilities on their own will not ensure that bottom 40% people get their due. And this scheme is going to ensure that when we create supply, that supply is used for the bottom 40% people.
But Mr. Bhushan, the obvious question then is that obviously I'm sure there's a back of envelope calculation that has been done on the ripple effects that the scheme will have in terms of job creations, in terms of new hospitals being set up in tier 1, tier 2, tier 3 cities. Will you help us understand what is your assessment and at what stage do we look at hospital consolidation really going forward?
We foresee two types of things happening in coming years. One is in tier 2, tier 3 cities, and even in rural areas, there will be more private sector providers. Many of these large hospital chains will see that business opportunity and try to open their outlets there. But more than that, probably they'll also get into some partnership with the local providers and provide some franchisee arrangements where they can ensure quality and provide supervision and have that kind of contract. A second strand that we see is that maybe more and more we'll be using telemedicine and artificial intelligence so that highly specialized skills, which of course can't be replicated, may still be covering large area through IT. So I think both of them should happen. And going back to your first question, that in terms of creation of jobs, back of the envelope calculation, our calculation is that in the long run, I think more than 2 lakh jobs will be created in the field of health sector, insurance, administration and support services.
Right. Okay, a very quick question then follows up on what will be the premium rates for Ayushman Bharat scheme. The IMA, that's the Indian Medical Association, had objected the package rates, fund allocation and the insurance model of implementation. The IMA had raised the need for scientific costing before fixing the rates. Could you explain what their demand is and how is the government responding to that, and what sort of premiums are we really looking at?
Okay, so there are two questions here. One is about the premium.
Yes.
Other is about the pricing and the contract packages pricing. So on the premium, now there are some states who are going for insurance model or the mixed model, and they will discover the premium through a bidding process. And so we've seen a range of premium. And that is understandable because premium will depend on many factors, including the healthcare seeking behavior in that state. So we've seen a premium of as low as 444 rupees per family in one state, and we've seen high premium of about 1500 rupees per family in one other state. So there is no one answer to that, and it depends on the availability of services and the cost of services and many other things. On the question of package prices, I think that has been a very hotly debated subject, and I have explained that our calculations are based on the existing information, and this is a very different kind of scheme. Many people have called game-changing scheme, and will provide a large volume of business for providers. So it's very difficult for us to assess what the correct pricing will be, and so current pricing is based on our experience in the existing schemes, and which may or may not be correct. And as and when we have more data and evidence available, we'll be looking at it again as a system. Now, IMA has had very intense discussion on this issue with us, and we have an agreement that let's start with these prices, but
right.
let's continue to look at it, and if more information, more evidence and more data can come in, we'll have a discussion again.
But Mr. Bhushan, because I think the cost of treatment will be very important for the beneficiaries eventually, the Association of Healthcare Providers of India, or AHPI as it's called, has said and analyzed that the government's health insurance scheme is only reimbursing private hospitals 12% to 58% of the actual cost. Are those allegations true? And the counterpoint to that is that if you do not fix or regulate prices for procedures, hospitalization, ICU targets, could the private sector be inflating that cost?
Well, I'm not 100% sure. Can you ask that question again? Because is the question that is private sector not picking up that cost?
No, my question
sorry about
is
that, because I think
in
between there was a disconnect.
Not an issue. I'm just saying that how do you arrive at cost? Because the Association of Healthcare Providers of India have very categorically said that they may just get part of the money that, you know, of the cost, 12% to 58%. But how is the government going to assess costs? In a free market, you would want the private sector to charge what they usually do. How are you then going to come in and regulate prices?
Okay, there are two issues here. One is how did we arrive at the cost? And you know, costing is not a very straightforward exercise. We can be talking about the marginal cost, or we can be talking about the average cost. If, for example, I am going from here to my home, and if someone else wants to ride with me, what is the cost that I should charge the person? That will be very different as compared to if you take a taxi from here to my home. So now the costing that we have done is based on looking at what kind of resources are needed for per cost basis, and also taking into account some of the fixed costs that hospitals have. But again, these fixed costs vary from place to place, and it's very difficult to have an assessment at the national level. And that's why these costs are indicative and suggestive for states, and they have the flexibility to change them based on their cost structure. So again, but we need to bring in a lot more sophistication in these estimates, and we'll do that. Now, second issue is that what should be our approach to cost? And we have been, frankly, very conservative in establishing these cost structure for prescribing these prices, because we are looking at providing support for 500 million people. And so we also are setting a watermark here in terms of pricing, and we don't want to be in a position, we want to make this scheme sustainable and keep a check on the cost of health services, because this will be important not only for the target group that we have, 500 million people, but also other people, because once there is a benchmark, for our scheme, I think the other prices will also somehow converge towards this. So we have this responsibility to ensure that with the increase in use of services, the cost of services doesn't escalate.
Okay, the cost shouldn't escalate. But sir, if I may ask a quick question, going back on the insurance premium, because this is the hotly debated topic. A lot of people who are detractors of the scheme are saying that the argument that the larger number of beneficiaries, the lower the premium will be irrelevant, because states will independently tender for beneficiaries as per central norms, just like they did in the Rashtriya Swasthya Bima Yojana. how are you going to defend the argument that the larger number of beneficiaries, the lower the insurance premium will be? And could insurance companies be the biggest beneficiaries of this really?
Okay, there are two questions here. One is whether large amount of resources will go to insurance companies, they'll be beneficiaries. I think we've addressed that issue by putting a provision that if the claim ratio is less than 85%, for example, the premium is 100 rupees and the total claim paid by an insurance company is only 75. So they are not going to give this 25% as their profit. They have to refund anything below 85%. So we put a cap on any windfall gains that the insurance companies will have.
Okay.
On the second issue of whether the larger pool of beneficiaries will reduce insurance premium, I think evidence from all over the world suggests that as the pool increases, the insurance premium goes down, because then it becomes more systemic rather than so actuarial calculation will show that as the pool increases, there's more certainty in terms of how it go, and that brings down the premium. So I don't buy the argument that with the increasing number of people, premium is not going to come down.
Mr. Bhushan, two quick last questions, and one of them has to do with states. As of now, you have decided that the cost sharing would be 60-40 ratio between the center and the states, but a lot of the states, politics aside, have similar healthcare schemes. Are they on board with yet another scheme that's coming in from the center? And the second question is that how are states choosing between the trust mode and the insurance mode of payment? 7 states, I'm given to understand, are votaries of the insurance mode. About 18 on states want the trust mode, where you actually reimburse the bill for the beneficiary.
Okay, so your question about whether states will find it difficult to provide their 40% share. So as you mentioned, that many states have their own schemes, and they are actually spending a lot of money on providing assurance and coverage for those schemes. And actually it's much easier for those states to provide their 40%, because they're actually, in most cases, they're providing more than 40% already through those schemes. So when they merge their schemes with the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, they are actually getting a windfall of 60%, because they were spending more than 40% if you look at the whole scheme anyway. So they are getting resources from the center for large part of what they were already doing. The problem is in those states who did not have any schemes. And some of these states are very big, like UP and Bihar. They did not have any health insurance or assurance scheme, and they have to mobilize 40% of resources. It's much more difficult for them. But one has to see it in a bigger context, that India wants to increase the resources for health sector. We spend about 1% of GDP, 1.2% of GDP to be exact, on health care from the public resources, and our target is to increase that to 2.5% by 2025. And for doing that, we actually need to increase our health sector spending by 20%. So if you see it from that perspective, I think we need to provide more resources for health through reprioritization, better tax collection, and simply providing more resources for the health sector. So this scheme actually pushes those states who are spending less on health through this scheme. Your second question about insurance mode versus trust mode, you're right that many states, like our states, are divided between insurance, trust, and mixed mode. And this is actually very good for us, because it will give us some evidence in times to come about which kind of mode is best for providing coverage.
Right.
And all three modes have actually pluses and minuses. So at this stage, I won't say that which is the best one in the Indian context.
Mr. Bhushan, a quick last question, and I think the question always goes to the moolah. Eventually, it's all about the money. Where is the money going to come from? Is introducing a health cess a sufficient measure? According to the Niti Aayog, we can collect upwards of 11,000 crore rupees. But is that going to be all for a scheme as ambitious as this?
Well, frankly, I have not focused on that, where the money is going to come from. I think that is for our colleagues in Ministry of Finance and Niti Aayog to look for. My mandate has been to ensure that we design a scheme which provides maximum resources to our beneficiaries, and I'm working on ensuring that we have a system which is efficient, which can avoid leakages and can ensure that resources go straight to our beneficiaries.
And Mr. Bhushan, is there any truth to the fact that many private hospitals and insurance companies are actually shying away from this, but they're being coaxed to be a part of Ayushman Bharat? We also know New India Insurance walked out of a similar scheme in Rajasthan, and now the government may actually may twist their arms to be a part of something like this.
Well, frankly, that has not been our experience. We had many tenders issued for getting insurance companies in many states, and we've got a very good participation both from public sector and private sector companies, and so we have not had the reason for coaxing or twisting arms for insurance agencies to bid for these contracts.
Okay, on that note, Mr. Bhushan, thank you very much for joining us on this edition of the India Development Debate. Thank you very much for sparing your thoughts on what will perhaps be one of the most ambitious healthcare schemes that the living world has seen. India does need to spend a lot more on healthcare, and we do hope Ayushman Bharat will be a success. There are some uncertainties as far as the funding of that scheme is concerned, but like you rightly said, it's for the government to figure this one out. Thanks very much, Mr. Bhushan, for being with us.